All right, you guys, welcome back to another video lesson from ICU Advantage. In this lesson, we're going to continue our discussion talking about ICU drips, and we're going to finish our discussion specifically in talking about our sedation medications. But before we get too far in here, first off, I want to start off and say a special thanks to all of our subscribers who continue to come back and continue to watch our videos and support our channel. Really do appreciate you guys. And for everybody else, if this is your first time to the channel or watching one of our videos, then we do invite you to subscribe to our channel below. Make sure, though, you hit that bell icon and select all notifications. That way you'll get notified as soon as the lessons become available and you won't miss a lesson. All the subscriptions, the likes, the comments, they really go a long way to help support this channel, and for that I do want to thank you guys. And for those of you who don't know me, my name is Eddie Watson, and this is ICU Advantage. Alright, so continuing on, like I said, we're going to finish up our discussion here talking about sedation. In the last lesson, which I'm going to link to up above here, we talked about really what sedation is, the different reasons in which we're going to be using sedation in the ICU, as well as we talked about the ways in which we monitor our patients who are on sedation. And so for this lesson, we're going to finish things up and talk about the different medications that we use. So we're going to talk about a few different drugs in this lesson, and it's important to know that our drug selection, we're going to want to base this on factors that are going to be specific for the patient. And these are going to be things like the level of sedation that we want to achieve, as well as the duration of the sedation that we're hoping to get out of this. And so when we talk about these different medications, there's actually 4 categories that we can divide things up into. There's also a separate classification where there's 3 different types where we look at them being either short-term, intermediate-term, or long-acting. But for the purpose of this lesson, we're going to talk about the 4 categories, and then when we talk about each of the medications, I'll specifically address whether it would fall into either the short-term, intermediate, or long-acting category. So to start things off, we're going to begin with our benzodiazepines, or what we commonly refer to as our benzos. Now, our benzos are our most frequently used sedation within the ICU. And when we're using benzos, we're going to be expecting them to produce sedation, to reduce a patient's anxiety. They also have an anticonvulsant property, as well as a muscle relaxant property, and they also induce amnesia. So the way the benzos work is they actually will bind to our GABA receptors in the central nervous system, and they're going to modulate that specific inhibitory neurotransmitter. One of the really nice things, though, about the benzos is they have a really wide margin of safety, as well as flexibility in the ways in which we can administer it, the routes in which we can administer it. But over time, with prolonged use, tolerance can develop. One thing that's really important to keep an eye out with the benzo use is respiratory depression can be seen. This is especially in elderly, as well as when we're concurrently using them with some sort of analgesic. But fortunately, benzos are typically pretty blood pressure neutral. So this can be a really important benefit, especially if your patients are sick and hypotensive. And with the benzo use, we're not typically going to see that work against us. But unfortunately, with benzos, they have found associations with ICU delirium. So certainly use these with caution, and again makes the case of all the more reason that we want to try to minimize or eliminate the use of sedation, whenever possible, of course. So within the benzo category, there's primarily 3 main benzos that you're going to see. First one is a medication called midazolam, or what you'll also hear referred to as Versed. The other is a medication called lorazepam, or what you'll hear referred to as Ativan. And the last one is a medication called diazepam, which also goes by Valium. And so when we look at these meds, our midazolam or Versed is going to be our short-acting benzo. Lorazepam or Ativan is going to be our intermediate-acting benzo. And diazepam or Valium is going to be our long-acting benzo. Now, in talking about Versed, this is one that we can either give bolus or in a continuous IV form. But if we are using it in a continuous infusion, especially for a long period of time, this can actually cause a buildup of the metabolite, and this is especially in patients who have renal or liver impairment and the elderly. And so really what this means is this can lead to longer effects than we would typically see with Versed. But Versed is probably one of the most popular forms of sedation that you're going to come across. Now, as far as our dosing goes, our typical bolus dose is usually going to be in the range of 0.5 to 2 milligrams, and our continuous IV doses are usually in the range of 2 to 20 milligrams per hour. So now moving over and talking about lorazepam or Ativan. Like I said, this one is an intermediate acting, and this benzo is actually the most common benzo that we see given in the ICU. Part of the reason for this is we can actually give it PO, IV push, or continuous IV. And because of this flexibility and its intermediate term action, it's something that we can give somebody and see the effects persist on for a decent amount of time. But one thing to know is, especially when we're dealing with the continuous infusions, is that Ativan is lipophilic. And this means when given in a continuous infusion, that the effects are going to last much longer because the medication is going to be built up in our patient's fat stores. So for these patients, depending how long they've been on the continuous infusion, it may take hours for them to wake up, or it may even take days. Now for Ativan, our typical bolus dose is going to be 0.5 to 2 milligrams. And when given in a continuous IV, our dose is usually going to be from 0.5 to 8 milligrams per hour. All right, so moving on to diazepam or Valium. Like we said, this is our long-acting benzo here. This one is rarely used in critical care for its sedative effects. Most often, you're going to encounter this one being used in the treatment of severe alcohol withdrawal. And this one can be given either PO or IV push, but it's not one that you're going to use continuously IV. All right, and the last thing that I want to mention here in talking about our benzos is our reversal for our benzos. And this is an important one to know. This is a medication called flumazenil or bromazicon. And this medication is what we call a benzodiazepine antagonist. And essentially, it will compete and bind with those same GABA receptors, but instead of activating them like the benzos do, it just takes up the space so that the benzos cannot. All right, so that is our first class here in talking about our sedation medications, the benzos. Now let's go ahead and move on and talk about the next category, which is our neuroleptics. So there's actually not a whole lot that I'm going to talk about with these. It's more just an awareness, because these are medications that are going to be used for patients who have psychological or some sort of behavioral component to their sedation needs. One really good benefit of the medications in this class, though, is they are a great treatment for delirium. And these meds are meds that aren't going to be given continuous IV, which is why we're really not going to spend much time talking about them. But I do want to make mention of them here. The first one is a medication called haloperidol, which also goes by the name Haldol. And the other one is quetiapine, which also goes by the name of Seroquel. So like I said, I'm not going to talk much about these, but these are medications that you're going to come across quite frequently in the ICU, so it is good to know them. All right, so moving on from here, the next class of medications that we're going to talk about are our barbiturates. And every time I hear barbiturates, for some reason, it always makes me think of 1970s, the counterculture and the drugs that were used back then. And just like they aren't really seen much in the recreational drug use these days anymore, we don't see a whole lot of use for these medications within the ICU, with a couple of special exceptions. And that's going to be because we typically reserve the use of our barbiturates for patients who have had a head injury and subsequently developed high ICPs, or for seizure burst suppression. And these medications can be quite effective in helping to lower a patient's ICPs or helping to really control that seizure activity, especially in patients in status. Now, these medications, they're going to end up decreasing our cerebral oxygen consumption, as well as decreasing the cerebral blood flow, and it may also scavenge free oxygen radicals. A couple important things to look out for, though, with this medication is it can cause excessive sedation, ultimately respiratory depression, and something unique within these sedatives, myocardial depression. So the last one, definitely something that you want to be keeping your eye out for if you have patients on this medication, although typically these patients will respond to a fluid challenge when you find yourself in a hypotensive state as a result of that decreased cardiac output from that depressed myocardial activity. Now, the one medication I do want to talk about within this class is a medication that we call pentobarbital. And like I said, we're using this one to try to decrease our patient's ICP and control the seizure activity. And really, we're doing this when all other interventions have failed for this patient. Now, for this medication, it's sometimes given in a bolus dose, which usually ranges from 5 to 15 milligrams per kilogram. And this is actually given over 1 to 2 hours. And then our typical continuous IV dose is going to be anywhere from 0.5 to 4 milligrams per kilogram per hour. But the way that we're going to determine the level of the pentobarbital that we want is we're going to base it off of our serum levels of the drug, which we typically want to see from 20 to 50 micrograms per ml. All right, so moving on from our barbiturates, the last category that I'm going to talk about is one that we call our other agents or our miscellaneous agents. Now, there's 3 different drugs I'm going to talk about within this category, and each of them are quite a bit different from one another. The first of these medications is a medication we call propofol, also goes by the name Diprivan. The next medication is a medication called dexmedetomidine, which also goes by the name Precedex. And the last medication in this category is one called ketamine. All right, so let's start off in talking about propofol. And propofol is interesting because it's actually a general anesthetic, which has been given approval to be used within the ICU setting. Now, propofol is our preferred drug of choice, especially for short-term sedation or when we have a need for the drug to be rapidly turned off. And the reason for this is that propofol has a very rapid onset and a very short duration, especially when we're comparing it to our benzos. So this is going to be very useful, like I said, in those situations where you need the patient to wake up quickly. One of the best examples I can think of this is if you have a patient who's requiring frequent neurochecks, but also is needing sedation, propofol is going to be a great choice. Now, propofol is a lipid base, and so this is actually going to serve as a source of calories for your patient. And patients who are on extended doses or large doses, they're really going to require that we're monitoring their triglyceride levels. And because of this medication is also going to require that we're frequently changing the IV tubing in order to really prevent growth of microbes. So this is something that's typically done every 12 hours. Now, a couple of the effects to make sure that we're watching out for is it can cause respiratory depression, as well as it can lead to hypotension and bradycardia. Also, something to keep an eye out for that is pretty rare but is specific to propofol is something that we call propofol infusion syndrome. And this can be a very serious condition for your patient, and the way that this is going to manifest itself is going to be in hyperkalemia, some sort of potentially tachyarrhythmia, maybe even a bradycardia, rhabdomyolysis, a lactic acidosis in the presence of that hypertriglyceridemia. So now when it comes to the dose of the medication, propofol can be given in a bolus form, but be careful because this is going to depend state to state, as well as hospital to hospital in terms of your policy. In fact, a lot of places will require that a physician or anesthesia be present and or be the ones to be giving the bolus. And the most common reason that we're giving it as a bolus is typically going to be for intubation or some sort of procedure, but the dose for this is usually from 0.25 to 0.5 milligrams per kilogram. And our continuous IV doses are going to be from 5 to 75 micrograms per kilogram per minute, although certainly the doses can go higher than this. All right, so now let's move on and talk about our dexmedetomidine or our Precedex. So this medication is actually a short-acting alpha-2 receptor agonist that happens to have sedative properties. And so as a result of it being an alpha-2 agonist, that we can see bradycardia and hypotension. One of the really nice things, though, about Precedex is it doesn't cause any respiratory depression. And so that means you can continue using Precedex while you extubate your patient and even while they are extubated. And so your patients are going to be easily aroused and alert when you do give them stimulation. And so it has very minimal amnesic properties. But when using patients on this medication, good to know that it may require some sort of breakthrough dose of another sedative or some sort of analgesic in order to achieve the optimum state that you want for your patient. And there also have shown to be some benefits in using this in patients with delirium. Now, Precedex can also be given in a bolus, and if we do, it's typically 1 microgram per kilogram, and we give it over 10 minutes. And our typical infusion dose is going to be from 0.2 to 1.4 micrograms per kilogram per hour. All right, and so moving on to the last medication in this category is going to be ketamine. And ketamine is actually an analog of another more commonly used general anesthetic. Now, unique to ketamine is we're actually going to see analgesia with this medication. It is going to produce anesthesia and amnesia, but one of the great things about it is it does this without loss of consciousness. Important thing to know though with ketamine is that it can actually produce hallucinations for your patient, but we can really minimize this with concurrent benzo use along with this. Now, ketamine actually has sympathetic stimulation, and so when we're using this, we're actually going to see an increase in our patient's blood pressure and heart rate, which again really distinguishes it from these other sedatives. So ketamine has really been playing a big role in our pre-hospital setting, but we are starting to see it show up more and more within the hospital. I know burn units really have a history with using this medication, especially with those patients and their frequent painful dressing changes. But again, this is another medication that's important to know where your state board of nursing as well as your hospital stands, because sometimes the use of ketamine is only restricted to physicians. Also, another thing to know with ketamine is that we may see an increase in your patient's ICP, so make sure that we're using it with caution in patients with head injuries. One last thing that's really great about ketamine is it has a very quick onset, 1 to 2 minutes, and it only lasts about 5 to 10 minutes. So this can be a great option for procedural things, and like I said, we're beginning to see it make more of a presence within the hospital. Now, as far as our dosing goes, this can be given as a bolus, and that's usually from 0.1 to 1 milligram per kilogram. And this can also be given as a continuous infusion, and our dose here is usually going to be from 8 to 25 milligrams per hour. All right, so that wraps up our other agents that we talked about here. As you can see, 3 very unique sedative medications, but all also have some very beneficial effects that would make them our ideal choice in certain circumstances. All right, and so that is also going to wrap up the 4th and final category as we're talking about the sedation medications, and therefore is going to wrap up this series talking about sedation in the ICU and the medications that we use in ICU drip form. And so with that said, I do want to thank you guys so much for watching. I really hope that you found the information in this lesson and the previous lesson to be useful and beneficial for you. If you guys did, please go down below, hit that like button, as well as leave us a comment and let us know what you think, as well as any questions that you have. All of this really goes a long way to help support our channel in the eyes of the YouTube algorithm, so we really appreciate all that feedback. As we continue the series talking about ICU drips, we're going to be finishing up this series talking about our analgesics and then finally our paralytics. So make sure you guys keep an eye out for those lessons and make sure and subscribe and hit that bell if you haven't already so you'll be notified when those come out. And in the meantime, feel free to head on over and check out the last series of lessons that we did in which we took a look at the endocrine system. As always, thank you guys so much for watching and you guys have a great day.